My name is Kirk Geyer, and I'm the General Manager of Biomedica Diagnostics. On behalf of the Biomedica team, it's my pleasure to welcome you to our series of scientific discussions with key opinion leaders in the field of thrombosis and hemostasis. I hope that you will find these topics both informative and stimulating. At the end of each video, you will find an email address where you may send us your comments and opinions. We would also appreciate your suggestions for future topics that may interest you. Now, on behalf of Biomedica, please enjoy.
Welcome to COAG Conversations, an educational series sponsored by Biomedica Diagnostics of Windsor, Nova Scotia. I'm George Fritzma, faculty for the University of Alabama at Birmingham School of Medicine Division of Laboratory Medicine and proprietor of the Fritzma Factor, your interactive hemostasis resource, where we exchange current coagulation information. We welcome you to our three-part series, What Have We Learned about inflammation and thrombosis since the COVID-19 outbreak. Our guest is Dr. Brandon Henry, a physician scientist and investigative pathologist affiliated with the Cincinnati Children's Hospital Medical Center in Cincinnati, Ohio. To date, he has published over 300 articles, including 150 plus articles on SARS-CoV-2 infection, which have already been cited over 10,000 times. Dr. Henry is America's most published COVID-19 scientist. And according to a recent analysis of Scopus, he is ranked among the most published and most impactful researchers in the world of COVID-19. Dr. Henry is the leader of multiple international studies investigating COVID-19. His research focuses on the intersection of virology, immunology, and hemostasis. Over the last 2 years, he worked to unravel COVID-19 pathophysiology, elucidating the mechanisms driving COVID-19 associated coagulopathy, immunopathology, and multi-organ injury. Dr. Henry serves as an international advisor on COVID-19 response to multiple regional and national public health agencies, and is the chair of the International Federation of Clinical Chemistry and Laboratory Medicine SARS-CoV-2 Variants Working Group. Dr. Henry, do you have a few comments?
Hi, George. I'm excited to be here today. You know, the significant progress that we have made in studying COVID-19 associated coagulopathy over the last couple of years will pay many dividends in the years to come for many other thrombotic diseases. Indeed, it has become very clear to physicians and scientists that thrombosis and inflammation are inherently linked and that we can't study one in isolation without consideration of the other. So the major scientific advances in understanding thromboinflammation seen in COVID-19, I believe will cause a paradigm shift in our research approach to many other conditions such as myocardial infarction and stroke. This will not only advance our scientific knowledge, but really enable new therapeutic approaches, even novel diagnostics. So with that, I'm excited. Let's dive into our talk.
Thank you. That's very interesting. As I said, our overall title is What Have We Learned About Inflammation and Thrombosis since the COVID-19 outbreak? We will have three brief presentations, and beginning with part one, relationship of viral infection and inflammation, the foundation for thrombosis. Let me start, Dr. Henry. How can we describe the inflammatory pattern observed in SARS-CoV-2, and how does it compare to other infections and critical illnesses?
The pattern of inflammatory biomarkers we see in COVID-19 really reflects a state of thromboinflammation. We see a widespread dysregulation of the immune system with both strong pro and strong anti-inflammatory factors, though we often become a bit fixated on the pro-inflammatory side and we kind of forget about the anti-inflammatory side. Because of that, I'm a bit hesitant to describe what we see in COVID-19 as a cytokine storm. It's commonly used, but we'll jump back to that in a few minutes. We also see a biomarker pattern indicative of derangement of hemostasis. Even in relatively mild cases of COVID-19, we still see, some of these signs that, hemostasis, there's something going on there. And that may explain some of the long-term consequences of COVID-19, such as increased risk of myocardial infarction and stroke in patients who only had a mild case or even asymptomatic case. Let's jump to a few slides to discuss this a bit further, including how we got to where we are now. We'll make a comparison to a few other infections and critical illnesses. So, George, this is a paper that we did really early on in the pandemic. We were able to highlight what biomarkers really indicated progression to a severe or even fatal course of COVID-19. And it's quite broad. And it really indicates, that we see, widespread dysregulation of nearly every system in the body. We have multiple hematological changes. One, I like to point out is that we have a declining lymphocyte count, which would usually kind of, be an indicative marker of, an immunosuppressive state. But at the same time, we see elevated neutrophil counts. We see declining hemoglobin, and we'll talk a little bit about that a little bit later. We see, liver biomarkers. We see kidney biomarkers. We see high LDH, indicative of cell injury, myoglobin and cardiac troponin, cardiac biomarkers, and of course the coagulation on that side. The PT and the D dimer, at least very early on in the disease course, and we have a whole array of inflammatory, biomarkers that are elevated. We did a lot of detailed analysis in our own studies. And one of the interesting things that we found was that the anti-inflammatory cytokine response actually was a stronger predictor of disease outcome and disease progression than the pro-inflammatory response. So the anti-inflammatory markers had a greater predictive power than the pro-inflammatory markers. There was an interesting study that was done that compared, when we talk about comparing, how does it, COVID-19 look to sepsis, or how does COVID-19 look to ARDS or trauma, other critical illnesses? This was a really great study done by Mathis Cox. And what they did was they compared COVID-19 with ARDS to sepsis with ARDS, sepsis with no ARDS. And what they, as well as trauma and a couple other conditions, but what they found was that levels of all three cytokines that they measured, so tumor necrosis factor, interleukin-6, and interleukin-8, were significantly lower in patients with COVID-19 as compared to those with septic shock with ARDS. So as I think, a better way to say it is that we see an immune dysregulated immune state, but not necessarily a true cytokine storm. It's just a complete dysregulated immune response. So as my friends Giuseppe Lippe and Mario Pavani like to call it, it's a cytokine breeze more than a cytokine storm.
This is really interesting. It's a little bit of a different look than what most of us have been seeing for the last 2 years. Another question, I take a lot of interest in the coagulation mechanism. Does the coagulation mechanism itself contribute to COVID-19 pathophysiology?
Early on in the pandemic, my Italian colleagues and I were amongst the really first to begin to observe and publish that it appeared that COVID-19 outcomes were strongly associated with admission biomarkers indicative of some derangements in hemostasis. For example, we published an analysis early on showing that even mild thrombocytopenia at admission was associated with increased severity and mortality. And as SARS-CoV-2 spread around the world, this was followed by, the clinical observations of numerous major thrombotic events in patients with COVID-19, even in those with, no pre-existing history or baseline risk factors that would, suggest that they would, be subjected to these types of events. Now, over 2 years later, it's quite clear that COVID-19 is as much a pulmonary disease as it is a vascular disease. And I think it's both. It's a pulmonary and vascular disease. Well, at first, that coagulopathy is mostly limited to the pulmonary microvasculature. As the disease progresses, it becomes systemic, impacting the microvasculature of multiple organs, leading to multi-organ injury, AKI, cardiac injury, liver injury, etc. And eventually leading to, pulmonary and systemic macrothrombosis and embolic events. These are very strong drivers of patient prognosis and overall outcome. But the mechanistic picture is extremely complex. And despite 2 years of research, we are still working to unravel it all. I have a slide here I want to show you that shows a few of these, the mechanisms. This is a paper that we published in Mayo Clinic Proceedings, where we really dived into the meat of what COVID-19 associated coagulopathy is. And we can kind of highlight what the most frequent thrombotic events and complications we see in patients with COVID-19. Of course, we have our venous thromboemboli, the in situ pulmonary thrombosis, our arterial thromboemboli, like MI and stroke. You can see these even with long COVID, and many other systemic thromboemboli with DIC and systemic arterial events. And here's sort of what we have as sort of this overview of the mechanistic picture of what we think, at least based on the data that we have now, is really driving the pathogenesis of this COVID-19 associated coagulopathy. And I have to say, George, this is mostly an oversimplification, because the more and more it comes out, the more and more complex this picture gets, and we see how intricate everything is. But I think if I had to point out a few things that are really driving it, we have to go to, endothelial injury, right? Endothelial injury is really key. And that endothelial injury may be driven by the fact that the virus itself is damaging the endothelium. It may be inflammatory factors that are driving the endothelium, endothelial injury, right? But the endothelial injury is really at the heart, the mechanistic heart of what's driving COVID-19 associated coagulopathy. But of course, it's not the only factor. But endothelial injury results in increased release of von Willebrand's factor and inefficient cleavage of the ultra-large von Willebrand's factor molecules that we'll talk about a little bit, hopefully later in the talks if we have time. And then we have, many other factors. A few that I'd like to point out, for example, is release of plasminogen activator inhibitor 1, and this sort of will lead to a hypofibrinolysis. And then we have these neutrophil activation. This is becoming a new area of real focus, and I think it'll have major implications for almost every thrombotic disease. And we get these release of these what we call neutrophil extracellular traps, and these will lead to activation of blood coagulation. And then on top of it, we have patients who are, prolonged and, have prolonged immobilization, right? So it really becomes, a perfect storm where we have, components of, primary hemostasis being dysregulated. We have massive activation of platelets. We have activation of, a secondary hemostasis. We have inhibition of fibrinolysis, at least, a transient state of suppression of fibrinolysis. And then of course we have the inflammation factors, which are just feeding into this whole system. So it really becomes a messy, complicated picture that we see, in COVID-19. And over time, we'll continue to unravel this. But I think a lot of the fundamental mechanisms in the relationships between these different systems will play, a key role in helping us understand thromboinflammation and a variety of other disease states.
Thank you. I think a lot of us are trying to put this into one category or another. So let me just ask you this. If you could categorize the coagulopathy, would you call it a septic intravascular coagulation, what's labeled as SIC? Early on, people were saying, it was DIC. I think most of the early publications out of China said DIC. Or would you think it's a TMA, a thrombotic microangiopathy? Can we categorize it that way?
This is a great question, and it's a very challenging question to answer. Defining COVID-19 associated coagulopathy, or at least categorizing it according to our pre-pandemic clinical definitions of coagulopathies, is very difficult. First, SARS-CoV-2 is unique in that it seems to directly impact all facets of hemostasis, like I showed in the previous image. Primary hemostasis, secondary hemostasis, and fibrinolysis are all deranged, right? All of them. Second, I think we see components of DIC, SIC, and TMA in patients with severe COVID-19, all of them. We see components of them. Though overall, the thromboinflammation that we see in COVID-19, to me, and at least my opinion, best reflects a state of secondary thrombotic microangiopathy. Now, that's not to say that we do not see DIC in COVID-19, because we absolutely do see patients in the ICU with COVID-19 related DIC. But I do not think that is the predominant form or the predominant driver of COVID-19 associated coagulopathy. Although there are some characteristics of COVID-19 associated coagulopathy that are similar to DIC, such as increased D-dimer or a trend towards lower platelet counts, there are a number of distinctions. First, fibrinogen is increased in COVID-19 associated coagulopathy, which contradicts the presence of a consumption coagulopathy like DIC. Fibrinogen, like von Willebrand's factor and a number of other proteins, is an acute phase reactive. So those are increased in the presence of inflammation. Moreover, the thrombocytopenia and the increase in D-dimer does not reach the severity observed in DIC, such as in patients with sepsis. So based on the reported data to date, the D-dimer is really interesting. We believe that the elevated D-dimer that we see early in the disease course is reflective of pulmonary inflammation with local activation of blood coagulation, really within the lung. Initially, there's sufficient balance of TPA, tissue plasminogen activator, in relation to what I mentioned earlier, that plasminogen activator inhibitor, which inhibits fibrinolysis. So we have more than enough TPA, which allows for adequate, activation of fibrinolysis. However, as the disease progresses, there is consumption of plasminogen, as observed by the low plasma values in severe COVID-19 that we and other groups have published, along with inflammation-driven elevation of that PAI1 and depletion of TPA, which leads to a state of hypofibrinolysis, allowing sort of that perpetuation of pulmonary and then systemic thrombi. Let's jump to a few slides so I can sort of highlight why I think we see a secondary TMA type phenomenon. So I want to point out a few, interesting studies that we've done that really sort of highlight why I think we see a secondary TMA. This is one study we did where we looked at the balance between Adams TS13 and von Willebrand's factor. And what we've seen, in our research, we use in our studies, we've been using AKI, George, as our primary outcome measure. And the reason for that is that the hallmark organ injury of TMA is classically, acute kidney injury. And what we looked at was in patients with COVID-19, did the balance between Adams TS13 and von Willebrand's factor suggest a state of secondary thrombotic microangiopathy? And what we found was yes. And matter of fact, as we can see, severe AKI was associated with low levels of low Adams TS13 activity and high von Willebrand's factor antigen levels. Similarly, we've often also done multiple studies looking at complement, another really key player, right? Because TMA is really a thromboinflammatory disease with, many components, right? And complement plays a major role. We target complement for treating different forms of TMA, right? And we also saw similar things, that complement was reflective of severity. And in a multi-center study we did with my friend Zoltán Prohászka in Hungary, we found complement levels at admission did reflect our ability to predict a severe acute kidney injury in coronavirus disease 2019. And finally, another interesting, we looked directly for signs of endothelial injury and the relationship between COVID-19 associated AKI. And we looked at angiopoietin 2. Angiopoietin 2 enhances endothelial inflammation and hyperpermeability. And we also found, a similar picture that levels of angiopoietin 2 were associated with severe AKI and need for renal replacement therapy. So to me, this sort of starts to put together a picture, both from the clinical side and laboratory side, that what we sort of see as the main driver may be a secondary, thrombotic angiopathy.
Thank you. That's very interesting. The one thing we still wanted to talk about is some of the novel variants that have come along, such as Omicron. With respect to the pathophysiology and thrombosis, what does the future hold in this regard?
Yeah, I think this is a really important question, and it's a question that public's asking, scientists are asking, physicians are asking. At this point, we don't truly totally understand how the various combinations of mutations combined in the different variants impact pathophysiology, nor the prothrombotic state associated with COVID-19. There are a few important points to consider when trying to evaluate this. First, the viruses continue to diversify at an extremely rapid rate, I think, as we all know. And looking at just within Omicron, we now have numerous sublineages that we struggle to keep up with it. Now, it might be tempting to say, that all those sublineages, have minor differences and they're likely insignificant to the pathophysiology. But, just looking at two of the first sublineages of Omicron identified, BA1, which was responsible for the first wave of Omicron, it is now mostly run its course, versus BA2, the so-called stealth variant, not really stealth, but was so-called that early on, that's now dominating the world. There are more different mutations. They're more genetically different. BA1 versus BA2, than the original Wuhan strain in Delta, or Alpha versus Delta. In other words, BA1 and BA2 are more different from each other than Alpha, Beta, or Delta were from each other. So BA1 and BA2 are very distinct viruses, which makes interpreting the clinical data very challenging, as well as studying them in the lab, right? As they require different conditions to study. Second, while BA1 seemed to show a reduction in intrinsic severity. Some new data that just came out, sort of suggests that BA2, at least BA2.2, which was predominant in Hong Kong, retains the pathogenicity and mortality rates similar to that of the original virus in vaccinated persons. So in other words, it doesn't really have that mild aspect that we saw with BA1. And then going back to the pathology side, for BA1, evidence suggests that the virus actually prefers a different cell entry mechanism than that of the original Wuhan strain, preferring an endocytosis route over the TMPRSS2 mediated cell entry pathways. Now, in turn, what this really means, coming back to understanding of pathophysiology, was that we saw that BA1 has different tropism for tissues. Tropism is the capability of a virus to infect a distinct group of cells within the host. So we consider neurotropism or cardiac tropism or vascular tropism. And we don't totally understand what it is, but we know that the virus has different tropism just within the lung. Omicron BA1 prefers to replicate in the upper respiratory tract, one of the factors that makes it less pathogenic, as opposed to the lower respiratory tract preference that we saw with some like the Delta variant. Right, so this likely significantly impacts pathology, but we don't know how so yet in the context of the entire tissues of a human organism. Moreover, we don't understand this yet for the other sublineages we're now circulating, such as BA2 or BA4 and BA5, which were recently added to the WHO watch list. So hopefully we'll understand this better in time, but it's very challenging, and we certainly need to see how it plays out in pathophysiology and in turn the COVID-19 associated coagulopathy.
So it looks like we've got a long ways to go in characterizing all of these varieties.
Yeah, I think we still got a ways to go, but scientists are working on it day and night, and in time we'll have better understanding of how this virus behaves.
Very good. Well, this concludes today's conversation. Please join us again next month as we continue our discussion about what have we learned about inflammation and thrombosis since COVID-19 outbreak. Dr. Henry, thank you for your expertise, and thank you to our audience for your participation.